Thank you, Kate, Sharanjit, and the whole of the Wellcome Trust Lived Experience Advisors. A truly challenging set of recommendations and talks to ensure that research genuinely works for the people it is there to serve. If any of the content that you've seen so far today has excited you, or you've had any technical difficulties in seeing anything today, all of the conference will be available for a month after tomorrow on the RCP's platform. You'll be sent out a link to all of the content to rewatch whatever you want. We move quickly now on to our rapid fire talks, where we look to showcase and foster discussion of high quality mental health science and demonstrate the breadth of approaches integral to mental health science. Our co-chairs for this next session are Sarah Shenow, MQ Head of Research, and Arden Tomison from Thalamos Digital Mental Health. Sarah and Arden, over to you.
Hello and welcome to this set of rapid fire talks of mental health science at its finest. I'm Sarah Shenow, I'm Head of Research at MQ, and with me co-chairing I have Arden from Thalamos. Great to have you here, Arden. And this set of talks, I think, is really exciting. It's a group of, in many ways, they're nothing special. They are mental health scientists, of which there are many, but actually they're extraordinary because they're the best and the brightest who are using cutting-edge methods to tackle the problems that we're all facing, that are really challenging in our society. So in this little group, we're going to have EthelNakimuli-Mpungu from Uganda, who's talking about a randomized control trials that she did for a new psychological treatment for people in Uganda in low resource settings living with both depression and HIV/AIDS. We've got GolamKhandakar from the University of Bristol, who's talking about the role of inflammation in depression and heart disease. We've got RinaDutta from King's College London, who's talking about self-harm and suicidal behaviours in young people with the power of data science. We've got SymonKariuki from the KEMRI-Wellcome programme in Kenya, who's talking about co-occurring epilepsy and mental health problems and the power of big data and genetic sampling to understand new mechanisms. And then finally, PetraVertes from Cambridge University, who's talking about schizophrenia and what happens in brains, in young people's brains as schizophrenia is developing. So really exciting, really different set of topics and of methods, all together trying to make progress in how we can improve the lives of people who are struggling with mental health problems. So nothing more from me just now. I'm going to hand over to Arden.
Thank you, Sarah. Hello, everybody, and big thank you to MQ for having me along. My name's Arden. I'm the founder, CEO of Thalamos, which is a technology company that focuses on supporting those with acute mental illness. We are digitizing the Mental Health Act, so we help those who need care under the Mental Health Act get it more swiftly, simply and safely than they otherwise could. I've been involved with MQ for about 2 or 3 years now, and it's been an exciting 2 or 3 years. I think the work that we're starting to see come through from MQ is fantastic, and conferences like this, sessions like this are really what MQ does best, I think, to kind of bring everybody together. And for me, mental health science is particularly important and really exciting because for a while there's been an increasing awareness of mental illness and of the challenges faced by those with in mental health. But for me, it was great to see lots of awareness, but awareness isn't necessarily the answer. It could be a route to an answer. For me, the answer's always lied in science. Understanding the why and what we can do about it is most important. And so I'm kind of delighted to support MQ wherever I can to get more money into research into mental illness, which is obviously what they're all about. So thank you very much for having me. I'm really looking forward to these sessions. And first up, I believe we have EthelNakimuli-Mpungu from the Makerere, sorry, can't say that properly, the Makerere University in Uganda.
Hello, everyone. Thank you all for joining us in this MQ-Wellcome Mental Health Summit. 6 years ago, most persons living with HIV/AIDS in northern Uganda woke up every day feeling worthless, useless and hopeless, without interest in work, unable to feed or educate their children, and many spent most of their day drinking alcohol. These individuals had depression, but did not know this. Access to first-line psychotherapy for depression was limited. Previous research has shown that untreated depression is associated with several negative public health consequences, including work disability and poor HIV treatment outcomes. Back then, we knew that HIV care providers visited isolated communities to care for persons living with HIV/AIDS. So we trained these health workers, who in turn trained community health workers, to recognize and respond to depression by delivering group support psychotherapy, GSP. We decided to evaluate this strategy by examining the long-term effects of GSP compared to group HIV education, GHE, on depression, income generation, and virus suppression. We also investigated the mediating role of depression in the relationship between GSP and these two outcomes. We hypothesized that GSP would lead to a sustained greater reduction in depression than GHE, and this would be the mechanism through which income generation and virus suppression would be improved. In keeping with our hypothesis, GSP participants had greater reduction in depression cases than GHE participants at 6 months after treatment, and thereafter they were more likely to remain depression-free than GHE participants 24 months after treatment. The sustained reductions in depression speak to the potential utility of GSP and require replication in other low-resource settings. Unlike the GHE intervention, GSP has known active ingredients, including emotional and social support, positive coping skills, and income-generating skills, which are potent buffers against depression. The active ingredients not only address emotional symptoms, but also major risk factors for depression, including stigma, discrimination, and socioeconomic disadvantage. The improvement you see among GHE participants could be explained by therapeutic factors common to both interventions, such as a supportive environment and therapeutic alliance, which generate positive feelings. However, since GHE lacks the active ingredients of GSP, the positive feelings generated could not be sustained in the long term. GSP participants also reported more participation in income-generating activities and greater improvement in virus suppression than GHE participants. However, significant differences in improved virus suppression between GSP and GHE participants were only observed 24 months after the end of treatment. You may ask, why didn't viral load improve earlier? Previous research has shown that resolution of depression in persons living with HIV/AIDS was associated with increased CD4 cell counts and natural killer cell activity, which limit viral replication. As such, sustained remission of depression may be necessary to boost immunity to significantly suppress viral replication. Indeed, our mediation analysis indicate that a reduction in depression partially mediates the effect of GSP on virus suppression and the effect of GSP on income generation activities. Some limitations to be considered in interpreting our results include confounding bias, measurement error, misclassification bias, and attrition bias. However, these limitations are balanced by strengths, such as a large sample size, the real-world setting in which we conducted this study, high treatment adherence rates, and a 2-year follow-up period. In conclusion, depression treatment was more likely to increase income-generating activities and more likely to improve virus suppression in the long term than GHE. There is potential value in integrating GSP into existing HIV care platforms. GSP could save more families from hunger, enable children to stay in school, reduce HIV transmission, and promote economically productive communities. I thank you for your attention.
That was great. And now we've got GolamKhandakar, who's based now at the University of Bristol.
Hello, everyone. I'm GolamKhandakar, Professor of Psychiatry at the University of Bristol. I'll be presenting findings from my MQ Data Science Award that investigated whether inflammation could be a shared mechanism for the comorbidity between depression and heart disease. Depression and cardiovascular disease are highly comorbid. This comorbidity leads to reduced life expectancy and increased healthcare cost. Studies indicate a bidirectional association between heart disease and depression, which is not fully explained by confounding, suggesting that these conditions may share pathophysiologic mechanism. With the MQ grant, we investigated whether inflammation could be a shared mechanism for depression and heart disease. We tested causal associations, whether inflammation could be a causal risk factor for depression, particularly focusing on the issue of confounding. To address the issue of confounding, we used a genetic design called Mendelian randomization, which uses genetic variants as proxies for biomarkers to test whether association between a biomarker and a disease outcome could be causal or explained by confounding. So it tests whether, say, an inflammatory marker interleukin-6 and its association with depression, whether it's causal by using genetic variants regulating levels or activity of IL-6 with depression. If genetic variants regulating levels or activity of that biomarker is also associated with the disease outcome, it suggests that the association between the biomarker and the disease outcome is likely to have a causal basis. Our work from the UK Biobank cohort suggests that inflammation could be a common mechanism for depression and heart disease. We tested whether cardiovascular risk factors could be causally linked to depression, providing a means for identifying shared mechanisms. Using Mendelian randomization, we tested associations for over a dozen cardiometabolic risk factors with depression, utilizing samples of up to 370,000 individuals, including about 15,000 individuals with lifetime major depression. Out of all biomarkers we tested, we see potential causal associations for 3 biomarkers with depression, namely triglycerides, interleukin-6, and CRP. 2 of these are inflammatory markers, of course, IL-6 and CRP. Subsequently, in the biobank cohort, we further investigated associations of CRP and interleukin-6 in depression. Our findings, combining data from biobank cohort and a Dutch cohort called NESDA study, shows that inflammation is associated with a particular subtype of depressive symptoms, so-called somatic symptoms such as fatigue, sleep problem, appetite, and weight disturbance. Our work also points to a particular role for specific interleukin-6 signaling pathway being causally implicated in depression, so-called IL-6 trans signaling. Turning to early life origin of depression and cardiovascular comorbidity, we tested associations between cardiovascular risk factors and depressive symptoms in the ULSPEC cohort, and our findings show that associations between depressive symptoms and cardiovascular risk factors are detectable as early as in adolescence, and the association between childhood inflammation and depressive symptoms in adulthood is mediated by cardiovascular risk during adolescence. So in summary, findings from our MQ-funded research suggest that inflammation, particularly the interleukin-6 receptor pathway, could be a shared mechanism for depression and heart disease. Inflammation could play a causal role in depression, especially for so-called somatic symptoms. Association between depressive symptoms and cardiovascular risk factors is detectable as early as in adolescence. Childhood inflammation may increase the risk of depression in early adulthood by influencing cardiovascular risk in adolescence. I'd like to thank my colleagues, Anna Chaplin, Zhang Yi, and Nils Koppelman for their work, MQ for funding this work, and I'd like to highlight our textbook of immunopsychiatry that will be published by Cambridge University Press next month. And thank you all for listening.
So that was great. Thank you, Golam. And I'm now going to hand over to Rina from King's College London, who's talking about self-harm and suicide.
Yes, hello everyone. So I'm going to be talking about how we use data science to understand educational risk factors for self-harm and suicidality in young people. Now, obviously, this is a sensitive topic, and I'd like to give a trigger warning at this point. Nearly 1 in 10 young people self-harm or think about suicide, and this is of particular concern as we know that self-harm and suicidal thoughts are the biggest risk factors for someone attempting to take their own life. I'm currently working as a senior lecturer at King's and also as a consultant psychiatrist at the Maudsley Hospital, and these are my funders and a slide of my disclosures. In 2018, I was fortunate to be awarded a data science award to investigate whether linking routinely collected data from schools with mental health data can enhance the understanding of potential risk factors for self-harm and suicidality amongst pupils. The crucial step, which I shall focus on today, was to identify those 11 to 17-year-olds known to SLAM, or South London and Maudsley, who had suicidal thoughts or behaviours using a routine anonymised electronic health record system called the CRIS system, which has been developed to allow researchers to study anonymised information extracted from the Trust's health records. The area that SLAM serves is 4 boroughs: Lambeth, Southwark, Lewisham and Croydon, shown here, and about 5,000 to 6,000 children and young people under the age of 18 are seen per year. We looked at a sample of individuals from 2009 to 2013, and we, as I say, used the CRIS system to analyse free text data. We aim to use natural language processing, or NLP, to extract data from the free text clinical records. Our rule-based NLP tool was developed using Context software, and it identifies positive and negated mentions of suicidality. So how did we do this? Well, I say we, but the majority of the hard work was actually done by a specialist trainee doctor in child psychiatry called Sophie Epstein, who I funded partly through the MQ Award for a year, and she's now undertaking an MRC doctoral training fellowship, extending the work. All documents for a random subset of 200 patients were extracted for manual review, and 100 formed the training set, and we kept aside 100 patients for the test set, and each had about 2,600 documents in them. We have done previous studies and reviewed other studies, and this was used to guide the definition of suicide-related information and suicidal behaviour. So in summary, at the top here, you can see any mentions that indicated the desire to kill oneself, end one's life, or wishing to be dead or to die, including having tried to kill oneself, were included. Mentions related to self-harm without suicidal intent or no explicit mention of suicidal intent were excluded. Now, Sophie manually reviewed and annotated each document to say whether they were non-relevant, suicidal, non-suicidal or uncertain. And for those documents that she labelled as suicidal, non-suicidal or uncertain, she also labelled mention level annotations. And because the purpose of our clinical use case was to generate a cohort of patients who had ever exhibited suicidal tendencies, we really prioritise detecting positive suicide-related information. So if there was even one affirmed mention of suicidality in a document, you can see here in 3, the decision rule was that they would be considered to be a suicidal patient. We checked inter-annotator agreement, which was really high, and we then went through a process of error analysis of false positives and false negatives and identifying additional target terms and negation terms so that the tool could be iteratively adapted to run over the test documents. The best performing tool had a sensitivity of 88% and PPV of 85% at the patient level. The value of our work is shown by the fact that using only structured risk assessment forms, just 6 of 37 patients, or 16%, would have been identified as at risk of suicidal behaviour. So those other 84% were only identified using our method. And as only 2 to 5% of the documents annotated contain suicide-related information in the affirmative, automating the identification of suicidality could clearly be of immense value in identifying patients at times in their lives when they are most at risk, so we can provide support in a responsive way. By linking this data with school reports, studies are currently underway to identify the school-related factors which may predict increased risk of self-harm and suicidal behaviour. And we're also doing further research based on the methodology developed, including in other countries such as the US, and for other issues such as eating disorders. Thank you. And I'd like to acknowledge my team in this next slide, because science is not possible without the effort of many, many people. And next, I'd like to introduce Dr. SymonKariuki from the KEMRI-Wellcome Trust Research Programme in Kenya.
Thank you very much for the wonderful introduction. I'm very delighted to be speaking in this year's Mental Health Science Summit, and I'll be speaking to you about neuroscience research in Kenya. So I'm based at the KEMRI-Wellcome Trust Research Program, and as you can see, it's located on the beautiful Kenyan coast, and we are very fortunate to have a demographic surveillance system, which is about 900 kilometers square, which provides a framework on which we conduct epidemiological studies, as well as any other surveillance studies. The program was founded in the year 1989, initially working on severe malaria, but subsequently evolving to cover important causes of morbidity and mortality in the area. So in addition to working in research, I'm also involved in advocacy and awareness initiatives, and I indicate there the role that I've played at the National Epilepsy Coordination Committee in Kenya, where I have been the chairman leading coordination of epilepsy activities in the country since 2016. I've also had an opportunity to serve in the advisory committee of the International Bureau for Epilepsy, the Africa region, specifically in the project on making epilepsy a health priority in Africa. And I am also a member of the task force on pediatric psychiatric issues, specifically which is under the Psychiatric Commission of the International League Against Epilepsy. And recently, in the year 2020, I got an opportunity to co-direct the neuroscience research, the KEMRI-Wellcome research program, and we cover a lot of research interests which are related to neuroscience, specifically clinical research, in which we run in neuroclinic and in the wards that see very young children with acute encephalopathy. We also focus on psychology and mental health, specifically in neurodevelopmental disorders, and also these conditions in adolescents, as well as the role of the health systems, including the MHGAP studies, then population health, specifically epidemiology interventions, as well as creating public awareness on mental health and neurological disorders, and genetics, looking at conditions that affect brain, specifically epilepsy and intellectual disability, as well as mental disorders such as psychosis and neurodevelopmental disorders. And we've also over the years set up cohort studies which have enabled us to do long-term follow-up of outcomes, as well as evaluating the long-term benefit of being vaccinated against infectious diseases. In the context of this MQ funding, we've conducted a number of studies, and the most important ones have been able to show that mental and neurological disorders are very common in children and adults on the Kenyan coast. And as you can see on the left there, about 22% of young children will have mental health problems. And more often than not, these mental health problems occur with seizure disorders, which in children, the commonest one is acute seizures. And in adults, we do see so many adults presenting to hospital with a spectrum of mental health conditions, and the commonest ones being psychotic disorders, bipolar disorders, and epilepsy, and also substance use disorder, which is common in this region. So we've only been able to understand the burden of epilepsy in this setting using community-based studies, and at the moment we have very few community-based studies on mental health problems. But one important finding that we found is that these conditions almost always occur in what is called morbidity. So specifically related to this MQ fellowship, we've been able to set up a number of genetic studies in collaboration with the Broad Institute and other partners, specifically EPI25. And through the fellowship, we've contributed multi-site genetic studies for genotyping all exome sequencing. First, for psychotic disorders, so far as of yesterday, we had contributed 2,799 cases. And then for epilepsy, we've contributed 1,604. And from this work, we've been able to get a number of publications, protocols published in BMJ Open on architecture of psychotic disorder, another protocol on architecture of neurodevelopmental disorders published in Neuron. And we've also been able to publish a paper on the utility of low-pass sequencing for known and novel variations in underrepresented populations, including Africans, in the American Journal of Human Genetics. And we also have so many other manuscripts that are being worked on by students, which are awaiting publications. So this work is hoped to continue beyond the end of MQ funding due this year, but we will continue giving the MQ updates on the progress with data collection as well as writing up and publication. Otherwise, thank you very much. And I would like to appreciate all these partners who have made this work possible. Many thanks. I would like to introduce PetraVertes of Cambridge University to give us the next talk.
Okay, so hi everyone. Before I begin, I'd like to thank MQ for inviting me to speak today. And I'd also like to highlight that my MQ fellowship is supported by the Stephen Palmer Fellowship Fund, which was set up jointly by MQ and the Palmer family, and for which I am very, very grateful. As you can see from this title slide, the focus of my MQ project is to combine very different kinds of data from macro scale to micro scale to transform our understanding of schizophrenia. And the motivation for this is that schizophrenia affects about 1% of the population, but the biological underpinnings are really poorly understood, and therefore current treatments often don't work or don't work well for a large fraction of people. I think part of the reason for this is that when we study schizophrenia and characterize it, we do so at a range of different scales, and these are often quite difficult to reconcile. The scale that is most accessible to us is the macro scale of data derived from neuroimaging, which can be performed in vivo. And if you think about functional MRI, for example, one analogy that always struck me is that if you think about the brain as an orchestra, then functional MRI is analogous to trying to understand the music performed by the orchestra based on infrared snapshots of the body heat generated by the musicians. So it really is a very macro scale, very derived kind of signal. And it's quite far away from the cellular scale at which disease processes and drugs actually operate. But imagine now that we were able to squish the orchestra and take about 1,000 samples from various locations. And then we could measure in each sample the composition, so the exact amount of wood and plastic and brass and resin that can be found in each location. This would give us a much richer picture that begins to build up an understanding of the sections of the orchestra, for example, which can then be combined with the more MRI type functional information. So it turns out that a very analogous data set was released a few years ago now by the Allen Institute for Brain Science. It took about a decade to compile. It's based on just 6 donor brains. But in each brain, they took 1,000 locations across the cortex, and they measured gene expression for all genes, so for 20,000 genes in each sample. This yields a large matrix of data of gene expression per these fine-grained brain regions. And you can think of this data set also as 20,000 maps, brain maps, showing you for each gene the expression pattern across the cortex. So for the last few years, a large focus of my work has been to combine this gene expression data from the Allen Brain Atlas together with macro scale data from brain scans. And the idea is that you can use brain scans in vivo to identify brain regions that are altered in disease or of interest in other ways. Sorry, and then you can combine this macroscale data with the Allen Brain Atlas using some statistical methods to extract a list of genes that together are overexpressed in the brain regions that are highlighted by the brain scan. Then you can use bioinformatic methods to try and further interpret this list of genes in terms of biological pathways and mechanisms that are enriched across these genes, or in terms of clusters of genes that interact with each other physically through protein-protein interactions. So we first decided to validate this method in 6 disorders of known genetic origin, and this was work led by Jacob Seidlitz and colleagues at the NIH. And what we found is that even though we know the genetic origin of these disorders, we start just from the neuroimaging data by constructing brain maps of structural alterations in each disorder. And then using the method I described before, combining with the Allen Brain Atlas, we're able to recover exactly the chromosome that we already know is responsible for each disorder, or even the portion of chromosome that is implicated in the disorder. So following this validation, we're able to apply the same methods now to more complex disorders that we don't understand yet at a genetic level. And my main focus, as I mentioned, is schizophrenia. This is work led by Sarah Morgan in collaboration with Ed Bulmore and others. And Sarah started by producing these brain maps of structural change that occurs in schizophrenia, and then using the method I described, combining it with the Allen Brain Atlas to obtain a list of genes. And then looking at the protein interactions amongst these genes, we were able to zoom in on a cluster of about 40 genes, which we feel are particularly important or overexpressed in the brain regions vulnerable to schizophrenia. And it turns out that many of these genes in the cluster are known risk genes or drug targets or otherwise genes that have been associated with schizophrenia in the past. And then many other genes in the cluster are currently still unknown. So this approach for linking the macro and micro scales together can be applied to really any type of MRI brain map or case control contrast, for example. And on the right here, I'm listing a few recent projects applying the same methods in different contexts. And I'm also just about to start advertising a postdoc position funded by MQ to take this work further. With that, I'd like to thank you for your attention, and I look forward to questions later.
Fantastic. Well, what a really interesting half hour and a brilliant session, frankly. I suppose 2 things came out of it for me, really. One is that investing in really innovative research can deliver the theoretical cutting edge stuff, but it can also deliver solutions now and immediate impact, which we can see from what's happening in South Africa. I think the other common thread that came through all of that, and I'm sure you'll agree, is that we've got to look at things holistically. So what was very clear was approaching not just the mental health challenge, but the physical health challenges at the same time and the cause and effects of each way. So yeah, I just applaud everybody there. That's really some great work, and well done to MQ for funding it.
Yeah, I totally agree. I was reflecting again, listening to those talks and also the COVID talk earlier on about the mind-body-brain interface and the importance of holistically looking at all 3 components, where traditionally we've siloed things off, and that came through for me, particularly listening to Golam talking about inflammation as that bidirectional causation with heart disease and depression. And I guess the other thing that really struck me was the way that Rina was able to go underneath the hood, so to speak, but not going underneath what the clinicians have written as a diagnosis or a category or a concern, using a greater level of granularity with the natural language processing methodology to find a whole, quite a
it was an enormously larger group, wasn't it, who really were needing some help. So really encouraging to see that holistic approach, but also that granularity, and what a diverse set of methods leading to change. So over to you, Lee.